In this module, we will discuss the immunological mechanisms underlying type II hypersensitivity. As a reminder, there are 4 types of hypersensitivity reactions, type 1, 2, 3, and 4. Type 2 is mediated primarily by IgG molecules. And type 2 hypersensitivity is, as I mentioned, is IgG mediated. And this can be a response to a foreign antigen. So for example, I've drawn here a red blood cell, and this red blood cell has covalently attached to penicillin molecules on its surface. Antibodies specific for those penicillin molecules can induce destruction of these red blood cells. Also, type 2 hypersensitivity can be driven by IgG recognition of self-antigens in an autoimmune reaction. So here is an example of a red blood cell specific antibody that mediates destruction of this red blood cell. So type 2 reactions are IgG-mediated damage to self or foreign antigens. Those foreign antigens have to be associated, however, with that self tissue. And it usually targets a specific cell or tissue rather than being non-specific systemic disease. And the damage can be either cytotoxic, which leads to destruction of the cell or tissue, or non-cytotoxic, which is typically a disruption in some way of cellular function. So let's talk about some of the mechanisms of cytotoxic destruction and non-cytotoxic destruction. So the first cytotoxic mechanism is complement-mediated inflammation. And so here we have an antibody that is bound to a red blood cell, and when that happens, it can activate the classical pathway of complement. And so it's recruited C1. C1 in turn has led to the cleavage of C2 and C4. This in turn leads to the formation of a C3 convertase, which rapidly cleaves C3 into C3b, and leads to the formation of a C5 convertase, which can cleave C5 into C5b. Now, the other portion of that cleavage is C3a and C5a. And as you'll recall from our complement module earlier in the course, these two molecules are potent inflammatory mediators. They act on endothelial cells within vessels to induce vasodilation, and they can induce neutrophil recruitment and activation. And so in this case, C3a and C5a can recruit neutrophils, induce them to degranulate. These granules are full of peroxidases and lysozymes and proteases and vasodilators, all sorts of goodies that we've talked about before. And the ensuing inflammatory response can induce death of the red blood cell. And this can lead to anemia, or if those antibodies attack platelets or neutrophils, it can lead to thrombocytopenia and neutropenia. The second mechanism is also mediated by complement, and this is complement-mediated cell lysis. And so in the previous slide, we showed the cleavage of C5 into C5a and C5b. When C5b associates with the cell surface of a red blood cell, it can then attract C6, C7, C8, and C9 to lead to the formation of a membrane attack complex. And this membrane attack complex, as we've discussed previously, induces holes or forms pores in the cell membrane until that cell lyses and is no longer functional. The third mechanism is opsonization, mediated by either complement fragments or by IgG. And so here we have a red blood cell coated with IgG molecules, or because of the activation of complement, it can also be coated with covalently attached C3b. Macrophages expressing Fc gamma receptors or C3b receptors can then phagocytose these red blood cells and destroy them within the phagolysosome. And then the final cytotoxic mechanism is antibody-dependent cell-mediated cytotoxicity, or ADCC. And while there are multiple cell types that can mediate this, the most important and the most efficient at doing this is the natural killer cell. Natural killer cells express Fc gamma receptors. These Fc gamma receptors can bind to IgG that are specific for red blood cells. This allows this natural killer cell to target the red blood cell and deliver cytolytic granules, including the molecules granzyme B and perforin, that in turn lead to the apoptosis of that red blood cell. So there's a variety of ways that one can detect hypersensitivity reactions, but I wanted to draw to your attention one of the key ways to detect hemolytic hypersensitivity reaction, and that is through the Coombs test. There's a direct Coombs test in which a patient that is undergoing an autoimmune hemolytic event, their red blood cells, which should be bound already by autoantibodies, are incubated with anti-human IgG antibodies, and this is called Coombs reagent. And when this happens at the right concentration, it can lead to agglutination of these red blood cells and precipitation out of solution. And there's a number of diseases for which this is an important test. Autoimmune hemolytic anemia, in which there are antibodies to red blood cell antigens. Drug-induced hemolytic anemia, in which drugs covalently attach to red blood cells, and drug-specific IgG lead to red blood cell destruction. An example of that is antibodies to penicillin, as I showed in a previous slide. And hemolytic disease of the newborn, or erythroblastosis fetalis, which is the result of maternal IgG that crosses the placenta from an Rh negative mother that has been induced to make an antibody response by an Rh positive fetus. There's also an indirect Coombs test in which patient serum is incubated with lab red blood cells of expressing known antigens, for example, A or B antigens. And when this mixture is incubated with Coombs reagent, you can also get agglutination, and this is used for ABO typing and Rh screening. There are a number of other type 2 hypersensitivity reactions, and to varying extents, they all use these same cytolytic mechanisms of destruction. Rheumatic heart disease is one example. This is an example in which Streptococcus pyogenes induces antibodies that cross-react to mitral valve antigens and can induce mitral valve scarring. Guillain-Barré syndrome is a syndrome in which antibodies detect or bind to the myelin sheath, and so these anti-myelin sheath antibodies can lead to destruction of it, loss of muscle function. This particular syndrome is associated with some respiratory and GI infections, although the mechanisms whereby these infections induce anti-myelin antibodies are very poorly understood. And then there's a number of diseases where you can make just kind of a one-to-one association. So in Goodpasture syndrome, you have antibodies to the glomerular basement membrane and particularly collagen components of that membrane. In pernicious anemia, antibodies disrupt the function of parietal cells that make intrinsic factor. In pemphigus vulgaris, antibodies bind to epidermal cells and disrupt tight junctions. In immune thrombocytopenic purpura, antibodies bind to platelets. One important thing is that susceptibility can be driven by genetics. So, for example, HLA is strongly linked to many of these diseases, and it can be driven by environment. For example, Guillain-Barré syndrome and infectious history. But the triggers for many hypersensitivities just are not known, and so these diseases would be classified as idiopathic. Now, there are two non-cytotoxic mechanisms of type 2 hypersensitivity that I want to discuss. And the first is when autoantibodies become receptor antagonists, or in other words, they block a receptor from receiving a signal. And the example of this is myasthenia gravis. Now, under normal circumstances at the neuromuscular junction, the neurons release acetylcholine. This binds to acetylcholine receptors, leading to a biological effect. In the case of myasthenia gravis, autoantibodies to the acetylcholine receptor block the ability of acetylcholine to bind and mediate this effect, and further induces the down-regulation of these acetylcholine receptors from the surface. And this leads to a variety of symptoms, including muscle weakness in the eyes and face and upper limbs, and it can lead to difficulty speaking, chewing, and swallowing, and in very severe cases, difficulty breathing. The second non-cytotoxic mechanism is when antibodies bind to a receptor and induce an agonist signal. In other words, they induce that receptor to start signaling. And an example of this is Graves' disease, in which antibodies to the thyroid stimulating hormone receptor induce a positive signal by that receptor, leading to hyperthyroidism. There are a number of strategies for treating type 2 hypersensitivity reactions. One of those is what's known as intravenous immunoglobulins. These immunoglobulins can be injected. These are non-specific immunoglobulins, and when they're injected, they can basically competitively inhibit the function of FC receptors so that they can't bind to the autoantibodies, but are instead binding to these non-specific immunoglobulins. And this inhibits phagocytosis and it inhibits ADCC. Plasmapheresis is actually an option in certain cases, which is the removal of antibodies from plasma in a laboratory setting, following which the plasma is injected back into the patient. There are options for depleting B cells in very severe cases and life-threatening cases of type 2 hypersensitivity. You will remember rituximab from your molecule cells and cancer course. This is an antibody that binds to CD20 on B cells and induces apoptosis of those B cells. And so this is a very non-specific B cell depletion to disrupt antibody responses. And of course, there are other immunosuppressive drugs, and corticosteroids can commonly be used to treat type 2 hypersensitivity reactions. Take a moment to go over this summary, which will give a rundown of the mechanisms that we discussed today that lead to type 2 hypersensitivity reactions.